I'm going directly to the case. A young female came with fever. She was dengue positive 1 month back. There is a mild sense of choking. There is a family history of some heart disease in her mother. When she was operated, she succumbed in the operation theater. She didn't know what's the actual reason. There was mild chest discomfort with the pain radiating towards the jaw, typical anginal pain. And otherwise, the patient is hemodynamically stable. And this is the entry tickets. That's the patient's complaint and all these things. This is the ECG. Not much to say about it. Actually, the patient was admitted due to fever, but nobody auscultated. There were some sounds in the heart. There is some kind of early diastolic murmur. Actually, everybody missed that time. The patient was admitted with fever. This is the X-ray. So apparently, the patient is unassuming, a regular patient with fever. Now, when the echocardiography has been done and you get the thing, hugely dilated aorta, it is almost 6 centimeter. No apparent thing was detected. Just see the aorta. There is aortic regurgitation which was producing the sounds, and that's why the patient was in the echo lab. As there is a huge aneurysmal dilatation of the aorta, it has been checked, and you see there is a flap with a true lumen and pseudolumen, you can see. And this is the CT angio. You can see the same thing. Now I am putting both the things side by side. This is, yeah. So you can see on the right side you have got the echo finding. The flap is coming and going. On the left side you have got the CT finding. It is the pulmonary artery. The aorta will come a little later. Sorry for the slowness of the thing. You will find there is a dissection with true and pseudolumen well visible. The peculiarity about this dissection is that it is quite localized in the ascending aorta. It's not going beyond that. So this is the coronal section. You can see the dissection starts just above the aortic valve and it is spiral in direction. So it's not that important. The diagnosis is quite plain and simple. You can see the spiraling of the lesion. And this is the report, the localized aortic dissection in the root and the proximal ascending aorta. And the diagnosis is quite, it is a type A, Dipankar type 2. So nothing much about this patient. But the important thing is that the isolated, that's the familial thoracic aortic aneurysm and aortic dissection, the TARD syndrome, includes enlargement and dissection in more than 2 family members. Actually, the mother was having this dissection, which was not detected later on. I find out the papers and find that mother is having dissection. And it is basically mediated by different genes, and genes are responsible for the 20% of this mutation. It is inherited in autosomal dominant pattern. So any patient with a history of dissection should be evaluated. Retrospect thought process in this patient, that TAD is always a possibility in a patient where there is a family history, minimum cardiological complaints, maybe a presentation of serious cardiological disease. Fever need to be evaluated thoroughly, and never forget to auscultate the heart. You may get a sound that can be gold. So that's, I'm coming to the second case. So this is a simple case, but I think it's a wake-up call for us when we are seeing patients. This patient presented in the ER with a restlessness and inability to communicate. It's a sudden onset. History of mitral valve replacement with mechanical prosthesis is 1992. There is atrial fibrillation with multifocal VPCs. And this is the admission note. And this is the ECG of the and this is the patient. You see the patient is totally restless. The patient was having no weakness whatsoever, but the patient is restless and apparently drowsy. So this is how the patient presents in critical care unit. The saturation and the pulse is not a problem, but there is atrial fibrillation with multifocal ventricular ectopics. The mute point over here is that this is the atrial fibrillation going on in a patient who is having mitral valve prosthesis. So the CT scan shows there is a huge infarct into the left MCA territory. There is a frontoparietal infarct, and you can understand the cause of that infarct. There is spontaneous echo contrast in hugely dilated left ventricle. So that was probably the cause, but the responsible cause is probably the atrial fibrillation. Uh, this is a view taken in different perspective, and this is the X-ray where you can see the mechanical prosthetic valve and hugely enlarged left ventricle and the left atrium. The main point about this patient is that infarction can occur in spite of anticoagulation. Poorly contractile heart in a spontaneous echo contrast does not a deterrent to produce a good pleth in pulse oximeter, and imaging is the gold standard. So I'm sorry, there is that's now this third patient. There is one thing which was not there. Actually, I uploaded the slide in the previous room, but it's missing. The atrial fibrillation is the commonest cause of this kind of cerebrovascular accident. Whatever you do with the mechanical prosthesis, if you do not correct the atrial fibrillation, always less presentation of a CVA is a possibility. Now, this case is again, this is the two X-ray I put side by side. The right one, you have seen this patient, and the left one is another patient where you can have some cardiac chamber enlargement, and it has to be the right-sided chamber enlargement. There is a problem with this patient because the patient is non-compliant. The patient came for something else. We have tried to establish something, and that's why she was not cooperating. She came with a recurrent chest discomfort. The coronary angiography has been done, and everything was done in quite a haphazard way. The hemoglobin was low. The coronary angiography was apparently normal. Okay, so this is the angiography. The important thing is that there is no LMCA. The LCX and LAD are originated different independently, and there is no aortic valve disease which has been detected. Actually, the absence of LMCA, and this is the angio report. What it's the commonest anatomical variant, the left circumflex and the left the LAD originated from two different places, and this is the commonest anatomical variant, around 0.4 to 0.6%, and it is associated with usually aortic valve disease. But here you can see the echo, the left ventricle, aorta apparently looking normal. The left atrium is also looking normal. This is the picture. The right atrium is hugely enlarged, and there is a communication of the right atrium with the ventricle. Actually, it's a direct garboard effect which was not detected. This is the thing, and this is the CT angio, which shows as the patient was non-compliant, so the dye couldn't be pushed. Otherwise, this is the right atrium, which is hugely enlarged, and there is calcification in the right atrium, suggesting it is for a prolonged period. So this came on the second phase, which ought to become on that slide. I'm sorry for that. So the take ICU message is that in critical care unit, echocardiography is mostly done in a modified way as the patient are not complying with the instruction. Multimodality imaging is helpful in diagnosing the cardiac disease. Medical approach helps to clinch the diagnosis, and apparently non-cardiological patient can present with serious cardiological problem. There are a couple of observations. What I find, all three patients' consent was obtained for presentation, but the enthusiasm was not there from the patient side. And I must thank the CSI for allowing me to present the case. I hope that I am on time.